الشيطان الرجيم بسم الله الرحمن الرحيم ولله ملك السماوات والأرض والله على كل شيء قدير إن في خلق السماوات والأرض واختلاف الليل والنهار لآيات لأولي الألباب الذين يذكرون الله قياما وقعودا وعلى جنوبهم ويتفكرون في خلق السماوات والأرض ربنا ما خلقت هذا باطلا سبحانك فقنا عذاب النار. In the name of Allah, the most gracious, most merciful. To Allah alone belongs the kingdom of the heavens and the earth, and Allah is most capable of everything. Indeed, in the creation of the heavens and the earth, and the alternation of the day and night, there are signs for people of reason. They are those who remember Allah while standing, sitting, and lying on their faces, and reflect on the creation of the heavens and the earth, and pray, Our Lord, you have not created all of this without purpose. Glory be to you. Protect us from the torment of the fire. Jazakallahu khair.
Jazakallah. Thank you, Saad. To commence our proceedings on the thematic session focusing on diagnostic safety, I would like to call on stage our co-chair for the session, Mr. Muhammad Arshad Kaim Khani, who is the CEO, Sehat Sahulat Program. Our moderator for the session, Dr. Miraj Shah, Chief Operating Officer, Aga Khan University Hospital, Secondary Hospitals, Pakistan. Please, sir. Esteemed guests, I present our distinguished panelists whose expertise in diagnostic safety promises an insightful discussion. I would like to call on stage Major General retired Dr. Amir Ikram, who is the ex-Executive Director, National Institute of Health. Please give him a round of applause. Ms. Afifa Baloch, who is the Patient Safety, Quality and Hospital Sector Officer, World Health Organization, Pakistan. Dr. Afifa. Dr. Miraj shall be taking over from here. Please, sir.
Bismillahirrahmanirrahim. Assalamu alaikum, distinguished guests, participants, students. It's my honor to moderate this session. I'm Miraj Shah, Chief Operating Officer for Off-Campus Hospitals, Pakistan, and it's a privilege to moderate this session and look forward to insightful presentations and a panel discussion after the presentation. So with the permission of chairs and co-chairs, if you allow, shall we start the session? All right. So our first presentation for this session today will be by Dr. Art Papier, CEO, Visual DX. So can we start with the presentation of Dr. Art Papier, please?
Good morning. This is Dr. Art Papier. I'm a dermatologist at the University of Rochester in Rochester, New York, and CEO of Visual DX, a health information technology company. It's really a pleasure to have the opportunity to speak at the 7th International Conference on Patient Safety, and I thank Dr. Zaki for inviting me to have the honor to speak. So today I'd like to talk to you about diagnosis, and I asked the question of what do these serious internal diseases have in common? Diseases such as Lyme disease, syphilis, meningococcemia, pellagra, sarcoidosis. These are all serious diseases that infect people with often serious consequences. What they have in common is they first can present on the skin, and they are often misdiagnosed. I want to jump into how we problem solve as physicians. How do we think? There's a wonderful book called Thinking Fast and Slow by Dr. Daniel Kahneman, where he poses the idea that humans problem solve two ways. One is system one, which is pattern recognition, and system two is analytical. So system one is fast. You see a problem and you know the answer without thinking. You see an image and you know what it is. It's automatic. You can't keep the answer out of your brain. Another example would be a dermatologist with experience could look at these pictures and go in the upper left and say herpes simplex, upper right, granuloma annulare, lower right, stria, and lower left, herpes zoster or shingles. So with experience, pattern recognition can be very, very quick, and you don't even need a medical history to figure out the diagnosis. Now, system two is analytical and takes time. So if we ask, what is 17 times 24? I don't think that's automatic for anybody in the audience. You have to perhaps think 10 times 24, 7 times 24, and add those two together and come up with 408. Now, it's instant for me because I've given this talk multiple times and I know what the answer is. So once I've learned that, it now is automatic when I see that equation. So if I said, what's the differential diagnosis of a 62-year-old male presenting with fever, arthralgias, and reticulate purpura, who has a history of end-stage renal disease, diabetes, hypertension, atrial fibrillation, I list the 10 medications. That's going to take time to come up with that differential diagnosis. That is not automatic. And not all pictures are automatic. So images, pictures, or patients with rashes can be ambiguous. These is just a pattern of widespread papules, erythematous papules in 4 different patients. And these are 4 different diagnoses that look very similar. In one case, it was viral exanthem. Another was a drug reaction. So you have to know, did the patient start a medication? And then you see this pattern and then you kind of figure it out. So you have to think about it. So not all rashes or visuals are pattern recognition. You might need to combine that with analytical thinking. So our brains are shifting between using pattern recognition on the one hand and using the cortex and analytical thinking of system 2 on the other. And mistakes are common. And so this is a diagram called the dual process model of diagnostic reasoning. And this was created by Dr. Pat Croscarey, an emergency physician and psychologist who's practiced in Halifax, Nova Scotia in Canada. And the basic idea, it's not that complex. The patient comes in, the pattern processor is our brain, and we automatically recognize it. We do that fast system 1 thinking, it goes right to the diagnosis. On the other hand, say you're a junior physician, and you're just starting out, you've never seen the pattern before. Now you got to think about it. And your ability to solve the problem is based on your intellectual ability, your education, your training, your critical thinking, your logical competence, rationality, and feedback that you've gotten during your career. So that takes time. Eventually you figure it out. It's not fast. a key part of this diagram is as you move through your career and you have more of these thinking experiences and feedback from making mistakes, you move more patterns into system one. So as you move through your career, you're able to do more and more fast decision making through system one. And so we prefer as humans system one. And we often make mistakes with system one because we're moving too fast and they're more prone to cognitive biases. So this is the dynamic. We really do need to think to problem solve, but we're wired for pattern recognition. And so system one is prone to cognitive biases. And these biases include ideas like premature closure, anchoring, overconfidence. There's dozens of these cognitive biases, these traps that we fall into when we're trying to do differential diagnosis and figure out what the patient has. And system two, when we're being analytical, is really limited by our training and our capacity of our brain. So an example of an important bias is representative bias. And this is the ideas that we're taught around the classic prototype of a disease, but the patient presents with a variant. So a 67-year-old woman presents to the emergency department with a toothache and fatigue and is triaged to the non-acute side where she sat for 5 hours having an atypical myocardial infarction. Alternatively, if I said a 67-year-old male smoker who's short of breath presents with crushing chest pain, pain down the left arm, lethargy, you'd automatically know that's an MI. That would be a classic MI. So representative bias has to do with training on the classic, and the patient comes in with an atypical presentation. And this is really important when we talk about hospital and healthcare quality and safety, that errors, diagnostic errors, are much more frequent around common diseases. If you look in the United States at the lawsuits that occur around malpractice, it is missed cancer, lung cancer, breast cancer, colon cancer, prostate cancer, missed myocardial infarction, missed stroke, missed pulmonary embolus, missed aneurysms. They're all diagnoses that we all know. So representative biases, those diagnoses presenting atypically, causes the majority of harm. We get excited when ChatGPT and large language models figure out a difficult case that we missed, but that's the most common scenario. And so the other bias that we've been very interested in our work is the pigmentary bias or racial bias. We've trained with imagery and education around rashes and light skin. The books have had biases, right? So erythema and purpura on white looks red or purple. Erythema and purpura on brown looks dark brown. It doesn't look red or purple. Another example, the striking example, would be meningococcemia. And you have on the white the obvious purpura, but on brown skin, it just looks like a dark brown. So that can cause error. So in our work, we're thinking about how do we develop information technology that can be used in the exam room. And it's not about just taking a book and putting it online. Like, what is the ideal interface of computer-based information on the desktop or the smartphone to improve decisions? And we believe that we need to support system one and also system two through graphics and imagery. And so we're taking, say, a differential diagnosis list of words and giving the end user the ability to see the rashes and how they present in diagrams to explain the key symptom patterns. And so the goal, both clinically and education, is to move away from just the brain to say that the brain, using computer-based information, is more powerful than the brain alone. And that includes machine learning, artificial intelligence, and rule-based systems. It doesn't matter what type of software. It's the idea that the clinician, the physician, is using information as they work, and that is more powerful than just trying to memorize it all. And so when we think about this patient, this is an example, another area of our work, this patient presented for 3 different times and had 3 different hospital admissions in 6 months for the wrong diagnosis. So this was a patient in a research study years ago. You see the pen lines where that emergency department or the A&E department put the pen lines looking for ascending redness. And really, they were thinking that it was cellulitis. So the red leg often gets premature closure. It must be cellulitis. Well, there are a lot of causes of the red leg, and there's a differential diagnosis of the red leg. And obviously, cellulitis is never bilateral. But this is a global problem. And the research shows that 30% of patients admitted for cellulitis do not have cellulitis. And this results in the unnecessary use of IV antibiotics. These patients might get C. difficile or MRSA infections. They'll have unnecessary hospital stays where they might fall. So a lot of downstream bad effects can happen from that diagnostic error. And in the United States, it's very expensive to hospitalize a patient. It's over $1 billion wasted in the United States on these admissions each year. So 50 years ago, we didn't have computers, we didn't have smartphones. We had books and journals. And the idea was that we would be good students, good residents in training, and lifelong learners, track all this information, and then as a generalist, see a different patient every 20 minutes. One patient has a headache, another patient has chest pain, another patient has a rash. And we're able to shift between all those patients, ask them the right questions, come up with a great differential diagnosis, nail it, give them the right therapy, and do that all from our brain. Well, that was a myth 50 years ago, and it's even more a myth now because the information keeps doubling. Every few years, the amount of information in medicine is exploding. So we need to start thinking about how we're going to augment our intelligence. So we're moving from this memory-assisted paradigm to being process-oriented, where we're using these tools and we're teaching our students about using information as you work. And so we're moving from unaided decisions to assisted decisions. And we're moving from manuals in the white coat to smartphones in the white coat. And from modeling roundsmanship, meaning the attending doctor is the all-knowing oracle that just impresses you with how smart they are, to an attending that says, look, it's impossible to memorize every drug reaction to every medication. Since the patient's on multiple medications, let's look it up and see together what medication might be causing this problem. And that's very, very different than just saying, I know. And so also in the past, it was the physician deciding alone. Here in the United States, there's a lot of emphasis on shared decision-making and giving people options to make sure they understand the choices that they have. A study that we ran, well, I should say the University of Maryland ran, a randomized control study of patients admitted in the ER. The emergency physician was admitting the patient for presumed cellulitis. When they went into the electronic health record to do the admission, they were randomized to get an alert. And the alert brought them to a computer workflow that asked them to answer a few questions. Is on the arm, hand, leg, foot, where you suspect cellulitis? Is it unilateral or bilateral? Is there lymphedema? They just answered a few questions, and then they received a differential. And they showed in the study that they were able to reduce unnecessary admissions by 38%. And so there are many different diagnoses that can cause a red leg. The number one error is premature closure on cellulitis when in fact it is stasis dermatitis. Very, very common for people to have lymphedema, their skin gets red, they might even have blistering, and there's this rush to judgment that it's cellulitis when it's an alternative diagnosis. Visual recognition, where I started this presentation, I said all these diseases present on the skin. The skin, it can be a window into internal disease, into infectious disease. We have lots of generalists, and we have, in the United States, we have lots of nurse practitioners and physician assistants that are seeing patients, and they don't have adequate training in dermatology. So there's a real need to improve pattern recognition skills. I really appreciate the opportunity that was afforded me to present to this patient safety conference. I'm available for questions. My email address is there, apapir@visualdx.com. We're always looking for international partnerships. Thank you so much.
Yes, please.
As panelists, I would like to call Dr. Mumtaz from National Institute of Health and Dr. Asim Belgwami, who is the CEO of Aga Khan University Hospital, to please grace us with their presence on stage.
Welcome. Though that was a recorded session, but I think Dr. Art Papier gave us a very insightful talk on the use of application AI and tools in minimizing diagnostic errors. I hope all of you are actively listening and engaged with the sessions. How would we know? All those students right there on the first floor. Are you all with us? आवाज नहीं आई ये हुई ना बात जबरदस्त. Thank you. All right, so with this first insightful presentation by Dr. Art Papier, we have another insightful talk by Dr. DJ Hamblin Brown, CEO and Clinical Safety Officer, Careful UK. So my request to start with the presentation of Dr. Brown.
Hey, my name is Dr. DJ Hamblin Brown. I'm the CEO of Careful, and I'm very grateful for Professor Ahmed for inviting me to give this short presentation on care coordination and safety. Thank you very much. I'm just going to share my screen, and hopefully that will bring up the title slide. So let me just remove that. So a little bit about me, and a little bit about the problems of care coordination. And I will tell you also a little bit about some evidence that we have about safety of handover and care coordination, and maybe tell you a little bit about the work that we've been doing here at Careful. So a little bit about me. I'm an emergency doctor by training, as senior NHS A&E consultant. My last substantive job was as the Vice President of Medical Affairs for a group of 7 hospitals based in Beijing, but was also the Group Medical Director for a group of hospitals in the UK as well. So I know something about clinical practice and also about managing risk and compliance. I have an interest in patient safety in particular. You're welcome to download this paper that we wrote on patient safety culture, which I think is an important component of any patient safety implementation. So let me tell you a little bit about some case studies around the issue of care coordination. Here's 2 from inside the hospital of my own experience. So a gentleman, a 57-year-old, who died on ICU because the ward failed to understand the need for a new prescription of antibiotics during his standing down to HDU from the critical care department. And on the right, a gentleman that I was responsible for whose critical CT was not relayed within the hospital, and he died of subdural hematoma. Outside the hospital, we have some interesting case studies, various different case studies. So father of 2 who had an HbA1c that made him pre-diabetic, had an MI a couple of years later, having not had his HbA1c repeated, and then this middle one is a 29-year-old who had a preterm birth because she hadn't had a flu vaccination, and a gentleman that was readmitted with sepsis as a result of a pressure sore which was not properly treated in the community. All of these failures are really about the lack of joined up teams, the lack of future focus on accountability of action, and a lack of clarity of information, particularly as patients cross boundaries inside the hospital or between hospital and community. So we believe that care coordination is central to patient safety, and these examples will explain why. Don't just take my word for it. The PwC produced a report in 2023 about care coordination, and they had this quote to say that it was basically an essential enabler for us to produce a sustainable, patient-centric and value-based future, which is to say that if you want a safe and reliable health system, you need to get care coordination right. Now, we haven't done so largely because for most of the 40 years that we've been digitizing healthcare, we've been digitizing the processes that surround the patient notes. And so we have a deep dive into each patient, but we've not been very good at digitizing whiteboards. This whiteboard is an example of a handwritten one. In fact, for patient confidentiality reasons, I've chosen one which is actually from a veterinary practice, but it's the same. We have loads of whiteboards, loads of spreadsheets, and lots of other messaging systems that go on and around hospital care, but we don't do well at digitizing these. So as a result, we tend to spend a lot of our time recording the past, using these big systems that we've developed. We spend a lot of our time using informal or in some other ways unconnected information systems in order to help manage care in the moment. And we spend very little time indeed talking about what we should be doing in the future and how we can find lists of relevant patients to understand what to do next for them. And people say, well, we should just join up our healthcare systems. Actually, creating data lakes and HIEs, in my view, doesn't in fact get us much closer. We just make a larger system of buff notes, if you like, folders of buff notes added together. So what evidence is there that this is a problem? Well, if we go to JAMA, there's two very famous papers here which show that the amount of miscommunication between primary and secondary care is huge. That when you go to your GP after you've been in hospital, almost all of the information that primary care physician will receive will be from you rather than from the hospital. Much of the data that is transferred across boundaries is wrong. That's one of the things that you can take away from this particular slide. And the Health Foundation, a think tank in the UK, made it very clear from a significant amount of research that they did that clinical care coordination improves quality and thereby safety and saves money. So a bit of research that my colleagues and I did a little while ago, which showed that the handover is seen as risky, seen as harmful, and is extremely error prone. In fact, in the same study, we found that a fifth of all practitioners used Word and Excel for handover, and 30% did not use their EPR at all for handover. In fact, only 13% used it exclusively. And almost half of the practitioners we surveyed said that they needed better electronic systems to support transitions of care. So just very briefly, I'll mention that we have been in Careful developing a system which allows everyone to see what is happening next with the patient. And when I say everyone involved in a patient's care can be given the opportunity to see what is happening and see particularly when the next action is and when it is due. The information then gives you access to cohorts of patients in a system which is simple to set up and shares key information across the different teams, whether they be inside the hospital or outside. And why would that work? Well, if you take our three examples from earlier, the gentleman with the diabetic screening problem would be within a diabetic screening team, and that screening team would know who has been screened and who has not, and it would not get lost within the GP's general management system. And again, you'd have a community antenatal team that would know which patients had had their flu vaccinations and which hadn't. And finally, the gentleman with the dressing, you'd be able to transfer information across organizational boundaries so that the discharge summary was freely available to everybody in the visiting team and know who was responsible for the dressing change. And so these systems that would cross boundaries would address this. I'll just mention that we have quite a lot of experience working in different parts of the world, and we also have experience of many different use cases, from cohort management, MDT facilitation, optimizing discharge, which of course is a significant problem for almost all hospitals. And finally, we can show that we've got some interesting results from that. Particularly, the one that I'm particularly interested in is the amount of time saved per clinical user per shift, to saving time on tedious handover and communication tasks. Anybody who's interested is welcome to get in touch with us and book a demo using this QR code. So at this point, I will take a break and say thank you very much to Professor Ahmed once again for inviting us to make this presentation, and look forward very much to anyone who would like to ask questions or to get in touch about this very important topic. Thank you very much.
Yes, go ahead. What an insightful talk by Dr. Brown. So with this, we have completed the two presentations, and now it's time for a panel discussion. So I welcome all the panelists. Major General retired Dr. Amar Ikram, Mr. Mohammad Arshad Khani, Dr. Asim Balgami, and Dr. Mumtaz Ali Khan. So before we start with the panel, the takeaway messages from both the presentations, if I ask anyone here, I mean, you may participate, we want to make it an engaging one. Just raise hands. What are the two take-home messages, if I ask you, from the two presentations? Anyone from the audience? We can provide you the mic. All right. Yes, please go ahead.
I think, we need to understand that the working in teams is the key to success, but also that's very difficult thing to do. And we need to design everything around this, even the hospital structures, the communication systems, the culture of the organization. Also, that the second thing is that the reporting and the documentation, it should not be around the patient record, and it should, we should have that, but the focus should be on what next actions are. What do we need to do in the future? That's the key, I think.
Thank you. Thank you for this warm applause. I love you all, your students. I wish I could come to you and have some questions from you, but hold it on till we have the panel discussion. कोई और comments तो नहीं किसी के in any of the two presentations? Yes, please.
Just one thing. Do not be too quick in making the diagnosis, as we clinicians do. Just have a group discussion before it, or the diagnostic test, for example, about cellulitis. This is quite true. That's it.
Good comment. Thank you for the feedback. And one thing that I really loved from these sessions was medical students, आप लोगों के white coat में manuals नहीं, smartphones होने चाहिए. Phones that can help you to really take the benefit of the artificial intelligence and technology and make good things. Okay, so let me have the privilege of starting the panel discussion. So I will pose a question as an icebreaker panel, so that from there on the next questions. So my first question is, both the presenters, sir, gave us a very encouraging message that using technology appropriately may help us to reduce errors. What are your insights about it? So we will start with Major General Dr. Amar Ikram.
Thank you so much. First of all, I'm extremely grateful to the organizer for inviting. And as we move on every year with the conference, I think it's great. And congratulations to Riphah, how they are progressing and how Dr. Zaki is taking along his passion at the national level. Coming back to both the presenters, I think there was plenty of good messages. You've already heard some of them again. And I truly believe, I mean, technology is a great support, whether talking of AI but the thing is how far we are going to utilize this AI. And with all that in mind, I think at the graduation level, when the basis and foundation is being made for a very, very noble profession, I think that's the key time to pick up all these things. And that is the time when you need to grow your brain much beyond. And I mean, then moving on to technology is a far better, because I mean, your mind needs to know what technology is also about to say. I mean, these are some of the key things. But as we move on, I think you have very clearly heard how a mistest or a misdiagnosis can transform the things, and how much of the expenditure, whether it's a public hospital or a private, for the public, the government has to afford, and for the public, private hospital, the patient has to afford. So, I mean, not only that, the agony attached to it. So overall, the composite patient safety, you have been hearing a lot in the previous conferences, but this time it's basically more tilted toward the diagnostic. And I would still like to add another perspective to it. Definitely, because considering not only the misdiagnosis, there are other factors attached to it. I mean, the patient, again, diagnostic safety is one of the components of patient safety. So the time the patient walks in, the time the patient is in the lab, or the time you see the sample, you stand responsible for safety of the patient over there equally as well, whether it's the laboratory side, whether it is the radiological side, in particular the radiological side, you know, the hazards and all those things. So how we are taking care. Unfortunately, we have seen so many arenas where these even x-rays are being done without full precautions. Now, yet another aspect attached to that is the cost of the test. Again, it's a public, definitely the government. And there is a huge trend of over prescribing the test that produces and induces a lot of burden on the government exchequer. And then moving on to the private side, and we have seen even the patients going to the lab, and once they hear about the rates of those tests, I mean, they would start narrating which is the most important test so that it could. This is the most unfortunate part, because again, it comes down under the patient safety aspect. In any case, as a diagnostic man, I would like to place it under the safety, because are we prescribing the right test to the patient? Are those which are mandatorily required? And is the patient in a capacity to afford? Are we asking the patient about that? So a multitude of things. As a doctors, as a youngsters, this is the message, that once you are prescribing anything, please go into the patient pocket and then see how much affordable the things are. And then use your clinical acumen to that extent, that what is the foremost and most prime thing to be advised as far as the diagnosis is concerned. So this is the message for the youngsters, because you are the future and you have to take care. Thank you.
Thank you, Major General Saab. Now I'll move to Dr. Hassan Bilgami. Your views about the messages given by our learned speakers, and anything you would like to add from your expertise as the Chief Medical Officer of the Aga Khan Health Services Pakistan.
Thank you, Dr. Miraj, and I'd like to thank Zaki and the whole organizing committee here for inviting me for this. So I really thought that these were both were somewhat similar, but they were different as well. One of them was talking more about diagnostic use of technology in diagnosis, and the other was talking mainly about use of technology in communication. And I think both aspects are incredibly important. But what really needs to happen is that we've got to think about not just the importance of that, but we've got to think about how we utilize or how we overcome those issues with the facility and the capacity that we have currently available. If we think about our smartphones in terms of diagnostic, we think about our smartphones, even Google is going to be able to give you a fair amount of information in there. And the importance of utilizing that lies in how you do that. And that requires certain background information. You cannot use these tools without any background information. I was in a session just before this, where we were talking about diagnostics and the quality of diagnostics. And one of the things that came up in there was being able to choose what to order. And to be able to do that is requires certain amount of knowledge and experience and expertise, not just about the patient and the disease itself, but also about that diagnostic tool. Would you get a PET scan for everything that looks like a space occupying lesion? Probably not. Actually, truly not. Because that's just going to lead you down a rabbit hole and lead to more problems and cost and delays in diagnosis. Although the PET scan is a sensitive tool, it is not a specific tool. And unless you know what its sensitivity and specificity is, you're not going to be able to use it properly. The same is there for the two technologies that were presented just now by the two eminent speakers, is to do with diagnostic variability. Yes, they are looking at certain patterns and they're trying to use that pattern recognition to help you come up with a diagnosis. But there's got to be there's going to be variability in those patterns. And therefore that pattern recognition has to be tempered, has to be based on your own experience and your own expertise and your own knowledge. The second is about communication. Tools will help communication, definitely. And we know that because we use WhatsApp all the time. We're all communicating with each other. Zurat ho na ho, hum WhatsApp kar rahe hote hain ek dusre ko. But the whole thing is, what is it that you're communicating and how you're doing that? And certain tools are in place. It could be SBAR or IPAS or whatever it is in terms of that communication. But the first and foremost thing is picking up that phone or walking over to somebody's office and having a conversation with them. And I think that face-to-face communication solves a lot of problems and solves a lot of issues. And again, even with that, it's not, the technology is not the be-all and end-all. Technology becomes a something that you can utilize as a tool that helps you, but is not the end. Thank you.
Thank you, Dr. Asim Bilgami. And now, Dr. Amir will request you to express your views about this session, and we'll catch more questions.
Thank you, and I'm really honored to be in front of all those experts sitting in the hall. And also, I'm looking that we have many students who are early career doctors or future doctors. So the session and theme of this conference is really important and to the point, because in situation like in Pakistan, we have much more patient for a doctor, much more patient for a nurse. So there is no time of thinking that what could be a diagnosis, what to write and what to do. But we have to think out of the box from both the presentations. I think the main message was out of box thinking. Don't see the patient with your predefined thinking that the patient came with fever and cough and it could be respiratory tract infection and simple. Or the patient came with abdominal pain and vomitings and fever, it could be appendicitis or something acute abdomen. It could be something else. As well as if we talk about new technologies, definitely Google Doctor is very famous nowadays. Everyone talks about Google Doctors. Even patient call you that I read on the Google that these symptoms correlate with this diagnosis. And the doctors are questioned. So for this reason, using new technologies, you must have background knowledge. You must have your experience. And keeping in view the history and physical examination, which is very important for a doctor. I think there is no break for that. If you take proper history, if you do good clinical examination, half of the diagnosis is there. As one of my panelists said, that diagnostic tools are just add to your diagnosis. This is not the overall dependency on diagnostic tools. You do X-ray test, you do any imaging, you do any test, you should know why you are doing that. What will answer? What question in your mind is? So physical examination and good clinical history is the backbone of your medical practice. And definitely a doctor should be good listener and good communicator. So based on those all things, the new technologies, the AI, the Google Doctor, the tools that can help you. But you should always search for authentic sites, for authentic information. Because in pandemics, during COVID, we have lots of information on the Google. Lots of uneducated guesses and uneducated, evidence-based things. And that is called infodemics. Many information. Barmar hai information ka Google pe. So definitely we should consult authentic sites, authentic organization for any consultation through AI. Thank you.
Thank you, Dr. Mumtaz. That was a very good. Now, coming out of the presentation and coming to the theme, and we would like to conclude in the next 10 minutes. This thematic session is about diagnostic safety. So just feel free. I will again request the three of the docs here to go through, and if I ask you to give 3 important messages to the audience in terms of diagnostic safety, what will be those 3 messages? जरूरी नहीं अगर 3 याद नहीं आए तो 2 में भी चलेगा काम. So, Major General साहब आपसे शुरू करते हैं, please.
Thank you so much. I think in the modern science world, you must remember, you must always remember that the patient is much more aware than it used to be in the past. We are talking of AI, you're talking of WhatsApp, you're talking of Google, whatever. There's every mother is a Google doctor nowadays. And my wife is not a doctor, but at times she claims she can make better diagnosis than me with my almost 40 years of experience. So this is the state of mind these days. So you have to deal your patient accordingly. This is the primary thing you must remember. The second thing is, as already pointed out, go for the right test. You must know what tests to be done and what are not to be done. You just heard about the PET scanner. This is one great example. But I mean, even coming down to the third one, from our perspective, is the diagnostic accuracy. The more you are accurate, the more precise is the diagnosis, the more timely is the treatment, and that in turn benefits the patient. So these are the 3 key messages that you need to put it in your mind, because AI is not going to put it in your mind. So you must keep them always with you. Thank you.
Thank you, sir. Please, warm applause for Major General Saab. Dr. Asif Al-Ghami.
Thank you, Miraj. So I actually think that I totally agree with what Dr. Amir said. We've got to remember that all of these things that we get, these are tools, and we've got to use them as tools. Certain types, we've got to understand that the diagnosis that we want to make is for the patient. And so everything that we do has really got to be patient specific. We've got to think about this particular patient, not a patient with a pneumonia or not a patient with a cervical mass or something of that sort. It's the patient that we've got to understand. We've got to understand what is happening around that particular condition that that patient has. And the decision to do certain tests or diagnostic procedures, and the decision to treat that person is going to be dependent not just on that diagnosis itself, but what is happening with that patient as well. Dr. Saab ne pehle kaha ke we've also got to be cognizant of what that patient can afford and what that patient cannot afford, and that is critical as well. What the system can afford and what the system cannot afford also. And so utilizing the right test for the right reason, for the right patient at the right time is critical.
Mumtaz Saab, well said, Dr. Belgami. Dr. Mumtaz.
Thank you. Sir, in Dr. Brown's presentation, we see in one of the slides, we saw that health data or health information is very crucial. So in countries like Pakistan, and especially in our country, we don't have proper and quality data. We don't do any research activities. And if we see hundreds of patients per week or per day, how many of them are getting noted and getting a proper record in our electronic medical record or in our books or research journals? So this can add to experience and add to things. So health data generation, quality of data is very important. Second thing is coordination and communication between the doctors, between the patient, and between the healthcare community. This is very important. And the last but not the least, we have to move from careless approach to careful approach.
Want to say something?
Well, my two cents at the end. We need to get out of the mindset of I know. That I know by the senior clinicians. I mean, that's a big issue. I remember in our days when patient used to walk in the OPD, तो professor बोलता था कि go and check the abdomen, forefinger and largest caliber, without seeing the patient, without seeing anything else. So we need to get out of this mindset. Number one. Number two, we need to have a correlation with the clinical correlation of whatever is required. And that, of course, use of technology is of tremendous importance. So these two, my few cents. Dr. Babar Saeed Khan, and I am one of the consultant WHO consultant who is developing national framework for patient safety and quality of care.
Big hand for Dr. Babar, please. Thank you. So before I hand over to the session's chairman साहब आपकी इजाज़त से मैं कुछ एक दो final remarks और so distinguished guests, students, friends, this was an absolutely fantastic session and great messages of how we can use technology to the extent we need to use to minimize diagnostic errors. And you heard one term again and again, the importance of communication. Now I'll ask a question. Yes and no is the answer. And this question is for all of you, the students sitting up there, right? Are you ready? Okay. Do you think communication is a big loophole in healthcare that leads to adverse events? सुनो अभी जवाब यूं देना है. अगर आप yes में आंसर देना चाहते हैं तो एक हाथ उठाएंगे, और अगर आप yes में आंसर देना चाहते हैं तो दो हाथ उठाएंगे, और अगर आप no में आंसर देना चाहते हैं तो सिर्फ एक हाथ उठाएंगे. आंसर दीजिए. किस बात का एहतजाज कर रहे हो भाई आप लोग? दोनों हाथ उठा के. Wonderful. A big hand for all the students there. They realize that communication is a big loophole. So never hesitate. One message that take-home message from my side as the moderator is, communication is the lifeblood of any organization, whether it's healthcare or whether it's manufacturing. And communication should be effective, timely, and complete. And don't hesitate to communicate in healthcare. And leaders, my humble request to all leaders from top to bottom, inculcate a culture where you remove psychological barriers from communications. Feel free to express. Chairman साहब इजाजत दें तो एक शेर याद आ रहा है जॉन एलिया का, अर्ज करूं. हाँ बच्चों, सुनेंगे शेर? तो सुने. इसका ताल्लुक कम्युनिकेशन से है कि शर्माना नहीं है, झिझकना नहीं है. अर्ज किया जॉन एलिया का शेर है, शर्म, दहशत, झिझक, परेशानी. शर्म, दहशत, झिझक, परेशानी अदाए नाज से काम क्यों नहीं लेती? ये, जी, वो, मगर ये सब क्या? तुम मेरा नाम क्यों नहीं लेती? تو شرمانا نہیں ہے, جھجکنا نہیں ہے. Thank you very much. This was a wonderful session. I will request our chairman, Mr. Qaim Khani, to please say the final remarks and conclude the session, sir.
Thank you. تم میرا نام کیوں نہیں لیتی؟ ہمارے ماڈریٹر صاحب فرما رہے تھے کہ تم میرا نام کیوں نہیں لیتی. ان کا نام لے ہی لیں تو بہتر ہے میرا خیال ہے. دیکھیے ڈائگنوسس کی بات ہو رہی ہے. زندگی میں سارا جھگڑا ہی ڈائگنوسس کا ہے. اگر ہم ڈائگنوسس کر لیں اپنے آپ کو تو بہت سارے زندگی کے مسئلے حل ہو جائیں گے. لیکن مسئلہ یہ ہے کہ ڈائگنوسس کرنے کے لیے اپنے آپ سے باہر نکل کے دیکھنا پڑتا ہے. ادروائز آپ کی ڈائگنوسس ٹھیک نہیں ہوتی. اور ہمارے ساتھ ایک عجیب ہی مسئلہ ہے, قبل اس کے کہ میں اس کی پروفیشنل سائٹ پہ جاؤں, کہ ہم نیشنل لیول پہ بھی میرا خیال ہے مس ڈائگنوسس کا شکار ہیں. دونوں سائڈیں غلط ڈائگنوسس کر رہی ہیں, جس کی وجہ سے ہمارا ڈائگنوسس کی وجہ سے, اس ایرر کی وجہ سے ٹریٹمنٹ بھی ٹھیک نہیں ہو رہا. تو وی نیڈ ٹو ڈو دا کریکٹ ڈائگنوسس. اور ڈائگنوسس کو اگر میں پروفیشنلی دیکھوں تو میں ایک تھوڑا سا واقعہ سناؤں کہ میں آئی واز وزٹنگ اے گلگت DHQ ہاسپٹل. I used to visit panel hospitals. تو ہم نے ریسنٹلی اسٹینڈرڈ ٹریٹمنٹ پروٹوکولز امپلیمنٹ کیے ہیں تاکہ ان نیسیسری سرجیکل انٹروینشنز یا ٹریٹمنٹس نہ ہو, غلطی کی گنجائش کم رہے. تو جو DHQ کے جو MS صاحب تھے وہ اتفاق سے سرجن تھے, جنرل سرجن تھے. وہ کہنے لگے کہ آپ کی جو صحت کارڈ کی ٹیم ہے بہت تنگ کرتی ہے. وہ کہتی ہے کہ جی سمپل اپینڈیکٹومی کے لیے پہلے اس کے TLC دیکھیں ایلیویٹڈ ہیں کہ نہیں, الٹرا ساؤنڈ کریں اور یہ کریں اور وہ کریں, کلینکل ایگزامینیشن کریں. یار میں تو جب مریض وارڈ کے کونے سے داخل ہوتا ہے وہیں دیکھ کے پہچان لیتا ہوں کہ یہ اس کی ڈائگنوسس اپینڈیسائٹس کی اپینڈیکٹومی کرنی پڑے گی. تو مجھے ہنسی آ گئی. میں نے کہا ڈاکٹر صاحب آپ تو کمال کے ڈاکٹر ہیں, آپ کو تو یہ میجک ٹرک آتی ہے, لیکن مسئلہ یہ کہ سارے آپ جتنے قابل نہیں ہیں. تو ہمیں پیشنٹ سیفٹی کے لیے ضروری ہے کہ اس مہربانی کر کے STPs کے اوپر اسٹینڈرڈ ٹریٹمنٹ پروٹوکولز پہ عمل کیا جائے تاکہ ہم لوگوں کی جان بچا سکیں. تو یہ بہت ضروری ہے کہ ڈائگنوسس, رائٹ ڈائگنوسس اینڈ رائٹ ٹریٹمنٹ. ڈائگنوسس کیا ہے؟ ڈائریکشن. اگر آپ نے اسلام آباد پنڈی کے بیچ میں میٹرو پہ سفر کیا ہو اور یہ دیکھے بغیر آپ چڑھ جائیں کہ میٹرو کا رخ اسلام آباد کی طرف ہے یا پنڈی کی طرف ہے, تو آپ کو اندازہ ہے کہ آپ غلط جگہ پہنچ جائیں گے, اور غلط جگہ پہنچنے کے پھر غلط نتائج ہوتے ہیں. اور ڈائگنوسس جو ہے وہ جیسا کہ بلگرامی صاحب نے بڑی اچھی بات کی کہ صحیح کانٹیکسٹ کے ساتھ, جو چیز ناخن کے ذریعے حل ہو سکتی ہے اس کے لیے فنگر استعمال نہیں کرنی ہوتی, اور جو چیز فنگر سے حل ہو جاتی ہے اس کے لیے بازو استعمال نہیں کرنا ہوتا. موسٹ کاسٹ افیکٹو, موسٹ ریئلسٹک اور موسٹ ریلیونٹ ڈائگنوسس آپ نے یوز کرنا ہے, چاہے مسئلہ کوئی بھی ہو. This is the only way forward. If you can do a right diagnosis, یقین مانیے کہ ایوریج ڈاکٹر میں اور عظیم ڈاکٹر میں کوئی فرق نہیں ہوتا سوائے ڈائگنوسس کے. Everybody knows therapies. That's not a big deal. Diagnosis and diagnosis. پاکستان کی جو گائناکولوجسٹ ہیں وہ کوئی میری شکل بہت پسند نہیں کرتی. The reason being میں جو پاکستان کی خواتین کے unnecessary C-sections کے خلاف ہوں. اس کے لیے میں نے یونیفائڈ پرائسنگ اسٹرکچر انٹروڈیوس کیا آج سے 8 سال پہلے صحت کارڈ کے پیشنٹس کے لیے, کہ چاہے آپ نارمل ڈیلیوری کروائیں یا C-section, آپ کو ایک ہی قیمت ملے گی, ایک ہی پیکج ملے گا. Just to de-incentivize the C-sections and just to incentivize the SVDs or the NVDs. I just requested them, please double check. آپ 2 دفعہ چیک کر لیں کہ واقعی مریض کو C-section کی ضرورت ہے کہ نہیں ہے. But of course there are vested interests and so many other things. اور جیسے کہ میرے بھائی عامر بتا رہے تھے کہ now in future AI is helping us. تو AI خود بتا دے گا. میرا خیال ہے میں کوئی مین پاور کی یا ہیومن انٹریکشن کی کوئی بہت ضرورت نہیں ہوگی. اور آنے والے وقت میں تو مجھے یہ ڈر لگتا ہے کہ جب میں اور آپ واٹس ایپ میسج کسی کو بھیج رہے ہوں گے یا آدھا گھنٹے سے کسی کو واٹس ایپ میسج نہیں بھیجا ہوگا تو AI بتا رہی ہوگی آج آپ کی طبیعت ٹھیک ہے. آپ نے جو ہے فلاں گرل فرینڈ کو یا فلاں چچا کو یا فلاں ماموں کو 2.25 گھنٹے سے فون نہیں کیا ہے, اس کا مطلب ہے تھوڑی سی ڈپریشن ہے. ٹیک ریسٹ فور 2 hours. تو دس از دا فیوچر. right diagnosis, right treatment is the right journey for the healthcare sector. Thank you.
Wonderful. So, ladies and gentlemen, with this, we come to the conclusion of this session. I'm really grateful to all the panelists, Chairman Saab, and all of you for your very engaging participation and listening. Thank you so much. Thank you.
To commence our proceedings on the plenary session focusing on global perspective of patient safety, I would like to call on stage our chairman for the session, Dr. Zafar Mirza, who is Professor, School of Universal Health Coverage, Shifa Tamir Millat University and Research Center, and also the esteemed former Special Assistant to Prime Minister for Health. So please, if you could grace us with your presence on stage. Yes, sir. Our moderator for the session is Dr. Zakiuddin Ahmed, who is Director, Riphah Institute of Healthcare Improvement and Safety, and Chairman, 7th ICPS. Second moderator is Dr. Asad Latif, who is Director, Center for Patient Safety, Aga Khan University Hospital. The transition to our panel discussion will be held by Ms. Leslie Thompson, who is CEO, Accreditation Canada. Ma'am, if you could please join us on stage. Ms. Rabab Diab, who is Deputy Chief Executive Officer at Healthcare Accreditation Council, Jordan. Please, a big round of applause for Ms. Rabab Diab. She's come all the way from Jordan for us. Mr. Sival Akhgun, Chief Quality Officer, Bishkent University Hospital Network, Turkey. Dr. Muhammad Saeed bin Hassan, Principal Faculty, Singh Health Duke Nas Institute for Patient Safety and Quality, Singapore. Last but not the least, Dr. Zaina Khoury Stevens, who is Managing Director, Noor Care Health Network and Managing Partner, Emerging Health International, UAE. Dr. Zakiuddin Ahmed will be taking from here. Sorry. Dr. Asad Latif will be taking from here. Please, sir.
Oh, there we go. Assalamu alaikum. नहीं, ऊपर वाले भी हैं. देखें, when I was asked to do this, I normally look at what the agenda says and what the topic is, and prepare some questions, share some with the panelists also, just so that nobody likes surprises. But one other thing that I learned to do is look at who I'm following. And the problem is I'm following Dr. Miraj Shah, and that's a tough act to follow. So let's start again. Assalamu alaikum. Sir, ऊपर बच्चे आपने charge up किया था लेकिन charge रहे नहीं. Excellent. So today we're going to be talking about the global perspectives of patient safety, and we have an esteemed panel and a great group over here with tremendous experience. And over the next hour, we're going to try and systematically pick their brain about how to touch upon this. But maybe we can start off with some open questions to the entire panel, and talk or ask about the difference between, we talk about quality and patient safety, but is there a difference between quality, accreditation, and patient safety? Because today we're going to be talking about the global perspective of patient safety. So maybe start off with the panel. What do you guys think? Is there a difference between quality, accreditation, and patient safety? And if so, what do you think it is? There's a mic right next to you.
Whom you are directing?
Sir, this one. Start with Dr. Zafar, please.
is working. Good evening again, and it's nice to be you in this session, and hope that you enjoyed the previous sessions. This is a tricky question, let's say, but is there difference between quality, patient safety, and accreditation? For me, quality and safety are the same. I always saying in my training, it is the coin with two different sides. Quality lead to safety and safety lead to quality. So quality and patient safety go together. We can't separate between them because with low quality, you will not achieve safety. With low safety, you will not achieve quality. So it's the same. Accreditation, it's kind of a framework that can support implementation of quality and patient safety programs. So you can use this tool for whatever you want the purpose or the objectives of implementation of this tool. So again, I'm emphasizing that accreditation is a tool. It's not an objective by itself or a purpose. So how you use this tool to improve quality and patient safety is the important thing. So this is my first thinking of quality, safety, and accreditation. I don't know.
Great.
I agree.
Well, maybe moving towards the other side of the table with the academics, with
I agree to some extent, but I think also patient safety is the building block. So quality, unfortunately, in some of our centers got a bad rap. Quality became the auditor of everything, right? If you had a quality department, the quality department was something separate than the rest of us working clinically. Patient safety sort of integrated those quality tenets and all the quality and translated it into clinical practice through patient safety tenets that we all work on. So yes, they go hand in hand, and you start with, but patient safety has become the implementation of all the quality venues that we know, all the quality principles that we know were translated into patient safety. For people that became practical. So that quality no longer is a theory. On the contrary, it's a practice that we do every day through patient safety.
I like to build on that. My name is Shahid. I'm a quality improvement and patient safety trainer, activist, facilitator in a hospital in Singapore. So I have, so in the place where I work at, we stopped calling it quality improvement. We prefer to call it improvement, just improvement. So we think about process improvement. We think about needing to measure to understand what is it what we're trying to improve. So of improvement that we think about are, number one, clinical quality. So you need measures, clinical quality. Patient safety is definitely one of it. We think of it in terms of reliability, how often you can get things right, and as few times things getting wrong. We think about efficiency, cost. We think about value, and the last one is experience, the patient experience as well as the staff's experience. So I think patient safety is one aspect of that. Patient safety to me is the prevention of harm, is the management of risk, and also one more for me, building a positive culture, taking care of your patients, taking care and giving assurance to your patients as well as your colleagues.
Fantastic.
Okay. Selamun Alaikum. First of all, I would like to thank the organizing committee and Dr. Zakiuddin Ahmed and Riphah Institute organizing such a wonderful conference like this and giving me opportunity to visit you frequently. This is my fourth time, and I'm really very much impressed with the enthusiasm and willingness to make your healthcare safer. And each year I see the big improvement. So I would like to congratulate, first of all of you. And, students, I'm professor of public health and medicine, and students are our future. And I'm very glad to see many students here. So I'm very impressed with the improvements and your enthusiasm. Regarding your question, actually, the final outcome is to make our healthcare safe. So patient and employee safety. Please do not forget also employee safety, because it's hands in hand, it goes together. So our final outcome is patient safety. Quality is very broad. I mean, when I first started to build all the systems and make our environment like you safe for our employees and patients, it was not so easy to find a way how to make improvement, how to improve, how to ensure the continuous quality improvement in our areas, and how to make our environment safe, because it's very broad and we did not have many tools that time. So accreditation in healthcare, I'm also working in accreditation in higher education. These are very good tools to show us the way how to ensure patient and employee safety, especially patient safety. So our final outcome is patient safety. We are using all those effective tools to improve patient safety and employee safety in our healthcare facilities. Thank you.
All right, great, fantastic. So I think there's consensus that accreditation is a set of standards to help achieve your goals, which is ultimate patient safety, but healthcare quality is more about effectiveness, efficiency, appropriateness of services. But while patient safety is a subset of this, a way of achieving this, other side of the coin, like you mentioned, focusing on preventing errors, minimizing risk, reducing harms. So while healthcare quality and accreditation encompasses a broader concepts of healthcare delivery and organizational excellence, patient safety really emphasizes the safety of patients receiving the healthcare services. And it's an essential component of healthcare quality, but it's not the entirety of it. It's a necessary part. So let's move on to some specific questions, and I'll start off with Leslie, maybe asking about what you feel are the most pressing concerns and challenges in ensuring patient safety on a global scale, and how do they differ from a national, subnational scale like we have in Pakistan?
So thank you very much. And one of the most pressing concerns that I see in working across over 40 countries and in every part of the healthcare ecosystem are the challenges related to the workforce. And I want to zero in on that as the number one. And that is around everything of thinking about how do we prepare the future workforce for the realities of the environment to improve quality and address quality and safety. And to this supporting the capacity and the capabilities of people that are working in the system to advance quality and safety. I think you need an integrated view of the support of the current and the future workforce. One of the things that we have done at Accreditation Canada in supporting Canadian organizations as well as moving worldwide is a specific workforce well-being instrument that looks at what is on the minds of the workforce, how safe do they feel, how trust they have in the management and the environment, how comfortable they feel disclosing incidents and challenges. And when you're able to link what's important to the workforce well-being to the drivers of a safety culture, you can generate actionable insights that will help shape that culture for the current and the future. We have been really learned a lot about the insights that come from this kind of analysis. The other thing is thinking about the preparation of the students in the future, of looking at the competency profiles of those professions. And in Canada, for example, we accredit all the schools for allied health professionals. And we learn a lot about what is needed to tie together the preparation of the future with the realities of the current environment. So workforce is number one, and every country is facing challenges. So you need to really be firm in that focus in order to keep people, to engage and excite people about the future. I am so impressed to see so many students here because that is the hope for the future, to be able to advance the big agenda for change to improve quality and safety across Pakistan.
Thank you. Very insightful. Switching gears and moving to Zaina next. So you have tremendous experience in various healthcare systems around the world, and in various positions. So how do you organizational and cultural differences, in your experience, impact approaches to patient safety initiatives? And what strategies can be implemented to ensure culturally or contextually sensitive care?
Thank you. So, the old saying goes, culture will always eat strategy for breakfast, right? So we can strategize and have the best strategies in place. But if we miss out on actually the local culture and the work culture, and I'm not just saying the culture of the country, but there's also the culture of the country to take into account, as well as the actual system you're working in and the culture of that workplace, and how do people work together? Do they work together? Do they not? So who have worked, and I came from a pure academic system, and I always said, and people would say to me in Saudi, what would Hopkins do? Well, it doesn't matter what would Hopkins do, because Hopkins can tell you something that gives you a best practice, but it's all about adapting that best practice to your culture. It's all about translating it and the implication it has on your practice that will matter, because I can't just take the dome. We say take the dome and plaster it all over the place. It doesn't matter. It doesn't work this way. What will work is if you get a true needs assessment, a true cultural assessment of what are your needs in that particular district, in that particular hospital system, and search the best practices that work it. And it may not be one source. It may be different sources that you put together the best of all worlds, the best of all other systems, and apply them to your system that is culturally accepted. So culture is probably your number one. And people that don't do well internationally are people that have minimized culture and the impact of culture on practices in everything we do, whether it's clinical, whether it's administrative, whether everything. So we really need to make sure that we understand the culture. I'm not Pakistani of origin. I've worked with Pakistanis for about 10 years now, if not more. But the last 2 years have I come to understand exactly what it will take and how, and the differences. And even in Pakistan, the nuances are different. The culture you face in Karachi is very different than the one you face in Lahore or even in Islamabad. And and yes, practice and best practices are the same, but it's all about how you translate them. You translate them very differently in Karachi than you would here in Islamabad. And that's very important for everyone, for all our leaders to understand and be able to translate that, to make it easier for the new generation that's working, the students. The curriculums are prescribed, but it's what happens after the curriculum. How are they going to become the best nurse they can or the best physician they can within the culture they're working in? It doesn't matter what they learned in the books, as long as they have the theory in. What happens really is the practice of medicine, the practice of nursing, that's going to make the difference. And that's all culturally based.
Thank you. So maybe, Sable, we can ask you about any successful examples, and I know you have so much experience, successful examples of innovative patient safety initiatives from your country or even around the world, and how can these be scaled or adapted to different healthcare settings and cultures?
Oh, okay. Thank you for this excellent question. Actually, yes, I will start from the beginning again. As you already mentioned that I'm working in the field now 40 years and 30 years in quality area. So I don't know that whether all those examples successful and innovative, because I will go back and now I will start 30 years ago. And I'm, you know, that I'm Turkish. I'm coming from Turkey. Our president changed the name, Turkey, but we are not used to say Turkey, so I'm always confused. And one of our colleague yesterday warned me that, yes, your country's name changed, but still you are using the same Turkey. But we are not used to, maybe it takes time. Anyway, so, how we start at the institutional level, because I'm working at the institutional level as well as at country level, not for only Turkey, but also for Saudi Arabia and for some other countries in Middle East area. The first thing is we should remember is measure. If you don't measure, you cannot make any improvement. So in our journey, as in the previous session, one of our colleagues also mentioned about the importance of effective health information system. So we made mandatory for each healthcare facility to have a good health information system in order to measure our current status and accordingly do some improvements. Okay. Then after, we moved the second step. We almost digitalize our system. So at the country level, we have electronic medical order system. We have incidence reporting system, which is very important in patient safety. I mean, at the institutional level, at most of the hospitals, yes, since the beginning, since many years. But at the country level, we have an instant reporting system. I'm not sure, and I cannot say you that, you know, very successful, because there's always underreporting. It's also same in the States, also same in Saudi Arabia or UAE. This is cultural, so it takes some time. So, but there's now a nationwide instant reporting system, nationwide adverse event reporting system. So, and all link to the centralized level. I know that it is not so easy for Pakistan, but I'm not coming also from a different environment. Maybe the discrepancy is not so high like your case, but still in Turkey also not a wealthy country, our economy not so good, and there are discrepancies between the regions. So, but measurement is really important in order to make any kind of improvement. Instant reporting, adverse event, reporting system. We understand our current station. Accordingly, we are doing some improvement projects. I mean, at the institutional level or at country level, and then. For diagnostic safety, we already listed diagnostic safety, and most of the, especially the biggest hospital, because nowadays maybe you are, following from media, medical tourism is very important for us. It is one of the main, financial resource, and especially from Europe and worldwide, we have a lot of patients around. We digitalize and we support the, for instance, diagnostic safety system with clinical decision support system. Okay, and we already mentioned and we discussed that accreditation or any kind of quality standards or requirements are a very good tool to make some improvements. So again, at nationwide, we developed our standards, okay, which is very similar to international standards. Of course, there are many hospitals accredited by international accreditation agencies, but not so much again, because we have 1,500 hospitals at primary health care, many 85 million population, and now we have around 15 million refugees all around. I think this is the number one country. So what we did, national standards, MOH made it also mandatory. So every year, MOH surveyors surveying the hospitals and looking at whether you met those standards or not, and scoring us, giving a score, okay? 90, 80 out of 100. If your hospital is over 90, okay, they are classifying the hospital A, B, C, D. So if your hospital is A, we have DRG system. I don't know, are you familiar with the DRG system? So again, for each procedure and each outcome, the Social Security Institute set up a certain amount. For instance, acute appendectomy. This is, let's say, $10. But if you are Group A hospital, you can, ask additional payment 2 or 3 times more than that certain amount, which is a good motivation for the. I think it's not good, but incentives always work sometimes, So it's a good motivation for especially private hospitals, okay? And it's a good motivation for all the healthcare facilities that everybody's in alert, because every year MOH is surveying and sometimes frustrated, but sometimes works well. Surveyors will come and survey us, okay? So this is second one. We have, of course, accreditation, national accreditation, but this is voluntary and independent organization. What I am saying is the mandatory one. So we are using the accreditation standards as a tool to make improvement and to, make our healthcare safe. And then we set up also some national safety goals. We have international safety goals, more than international safety goals, such as effective communication, identification, so on. So in our accreditation system, yes, these are the main issues that whether checking, the hospitals are doing well or not. Then training. What we did, and I work hard on this issue, our future is here. And Leslie already mentioned that workforce is very important. And we are also suffering, most of our healthcare professionals, especially doctors, moving to Europe so much. So I'm also really worrying too much that in the near future, and everything in my time, and still everything is in Turkish, but now, different population, diverse population, also this is also another problem. So effective communication is very, very important. Anyway, so you need to integrate all those patient safety issues into your curriculums, okay? So this is the most effective way indeed, I'm working in the field for many years, and the most difficult group for me, I'm physician for 40 years. Most difficult group is physician engagement into our patient safety activities. So if we would integrate all of these issues into curriculum, our life would be much more easier. I mean, when I say our life, I'm a quality officer, patient safety officer, and the leaders and leadership commitment, of course. I mean, I'm so lucky that I'm working in the same position for 30 years, and leadership support was excellent for me, so I was successful. So to be a successful, this is the first issue indeed. And the second one, you are very enthusiastic. I suggest you to integrate all these principles into your curriculum. We did it with Higher Education Council, except again medical colleges. Okay, medical colleges defense that patient safety is a science. I mean, it is not different than gastroenterology. Maybe much more, simple, but the leading causes that still it's at the first 3 rank. So patient safety issue is very important. Maybe not many people are dying from the other problems. I mean, are not dying from cancer or not dying from heart diseases as much as before. Now dying many patients because of medical errors that we are doing. Everybody is aware for that. So for our students, for our future workforce, I think we need to do this, integrate all these principles into our curriculum. Each healthcare professional, nurses are doing great. Nurses are always my very good friends and very good helpers. Yes, nurses are doing very well, and the others, allied healthcare professionals are also doing well. And our physician should be changed. And I think the first step should be the integration of all these issues into curriculum, and as much as possible use the technology. Technology really helps us, but we should be careful. We are forgetting to touch the patient. So our students, I observe that attitude to my students, that immediately sending the CT, MRI, so not touching, not listening. Listen, patient. Engage your patients' families into their care decision. In order to do this, you need to listen your patients. Yes, use technology, digitalize your healthcare. Try to, at least for one region, start, this digital health issues as piloting, and then, expand. But the most important thing is workforce, work on that, train, from the undergraduate level to postgraduate level. Thank you very much. Hope it is not so successful. I cannot say that we are very successful, but when we compare, when I compare 40 years ago and now, I think we did some progress like Pakistani group. Thank you very much.
Thank you, Dr. Akun. And you bring up excellent points that were echoed in the morning also about how physicians are often the most difficult group. And it sounds like the carrot and the stick ended up working for you, maybe more the stick than the carrot. So tying compensation at the national level to at the hospital level is a very interesting approach. Moving to Dr. Diab, I think building upon some of the issues that you mentioned, how do you think regulatory bodies and policymakers can collaborate with actual frontline healthcare providers to first establish, and I think we spoke about co-production yesterday as one of the necessary steps, and then enforce that patient safety priorities on a national scale. And if you take a step back, maybe on a global scale, if that's even possible.
Okay, thank you for this question, and it's very important to discuss. And when you talk about regulatory bodies, always it is like the physicians. It's a sensitive topic to talk about and discuss the role of regulatory bodies. But always I am saying we need to understand the principle that we use in quality and patient safety is nothing for me without me. And the regulator need to understand this also, that nothing for me as healthcare providers, as healthcare institutions without me. Without me means engaging me in the process of developing the required regulations and use the different approaches, top-down, down-top approach, but you need to engage the appropriate stakeholders from the front line until up to the leadership of organizations and all healthcare providers. So engagement is very important. The issues with regulations, I think, from our example in Jordan, we have all required rules and regulations. It is there, it is written in a very nice way. But the problem is the enforcement and the continuous implementation of those regulations. When we came as an accreditation body and start working in Jordan, as I mentioned, all regulations were there, but they were not enforced. So by using the accreditation as a tool again, it helped in enforcing the required regulations to be implemented. And it go as simple as implementation of fire safety system, which is already in the regulation, up to the clinical privileges of staff, infection control policies and the procedures, medication management, and all these things. So engagement is the first thing. Second thing is enforcement. And you can use different ways of integration of patient safety initiatives or patient safety projects in different ways. For example, also in Jordan, we don't use only the standards. We have, as Dr. Sibal mentioned, the national quality and patient safety goals, which is specific targets, specific goals that are announced every 2 to 3 years. And the organizations need to work in achieving those targets. And it's a prestigious award that is submitted by Her Royal Prince Mona, the mother of our king. So organizations are competing to achieve these goals. And this gives a big movement in the country toward patient safety. Because sometimes accreditation, it's a complex process, need a lot of resources. So organizations held back on implementation of patient safety. But with those goals, it encourages all organizations to work toward patient safety. Advocacy and awareness, it's not only writing the regulations, but also it's about advocacy and aware all stakeholders about the importance of those regulations. Sometimes the regulations are there, but nobody knows about them. And there is awareness about them. We have a recent experience developing the regulation related to the continuous professional development for healthcare providers. The approach that was used to develop this regulation was taking into consideration the most important part is the engagement of healthcare providers and the frontline staff in establishing this regulation. And also it took us 3 to 5 years to do only the advocacy and awareness about the importance of CBD, its relation with patient safety, its relation with the clinical care. So this is another example how regulations can be really enforced and implemented by the regulatory bodies. And also it's important to support with the appropriate systems. It's not only about regulation, you put the regulations and sometimes leave people how we are going to implement that. So the appropriate systems, and I'm not talking here about the sophisticated advanced technology, we are talking about the system. It could be a simple paper-based system up to using any technology that is available according to the resources. And all regulations related to patient safety cannot be enforced without accountability. Accountability is a major issue, and sometimes with the weak governance system within healthcare organizations, accountability is an issue. And from our experience in Jordan, we have an issue with the accountability, specifically when we are talking about the public sector. In the private sector, if you are not doing good, you will be accountable against your work, you will be fired from your work, but in the public sector, it's very difficult. So accountability is one of the important things, and piloting and testing also is an important step when you are implementing any regulation, not only for patient safety regulation. I will stop here and thank you.
Thank you very much, and no need to stop there. It's fascinating how you were able to do a top-down advocate incorporation of people's opinions when you're creating your standards, but actually took almost 5 years to advocate for before trying to implement them. And I think that sort of thoughtfulness pays dividends down the line rather than telling people what to do. I can't tell my 10-year-old what to do. Imagine a bunch of willful doctors. My 10-year-old's dependent on me. I have all financial control. Moving on to Dr. Shahid. And, you know, as a PhD scientist and a strong advocate and champion, as you say, we're going to come back to the question about technology. And so in what ways do you think technology has affected patient safety efforts globally? And a twist on it, has it really been all positive or are there negatives? And then, you know, in terms of emerging technology, what do you think will play the biggest role in the future?
So I think, can I answer based on what I think is the most exciting when it comes to technologies?
Yeah.
Okay, because I'm somebody who believes in user-centered design, human-centered design. So one of the most exciting emerging technologies that we have right now, and we are seeing it in Singapore, is digital technologies. There is in the digitizing of healthcare. So a lot of data is being collected at different touch points along care delivery, along the patient's journey, up to the point where patient can have access to their data directly on their smartphones. And we are trying to roll out such technologies that allow that. And I think this is one of the most exciting things about technology empowering patients to be part of the care. It gives them access to data about themselves, information about themselves that they can then work with their care providers to co-create the right kind of delivery for them, depending on what matters to them as a patient. And I think this is very exciting for me. It's really about putting the patient at the heart of the care delivery. Is it a positive thing or a negative thing? I think a previous panelist just now spoke about the difficulty of having Dr. Google. So now imagine Dr. Google plus information about your healthcare. And I think, yes, it opens up a longer conversation that the care provider, the healthcare provider needs to have with the patient. But I think that it gives a much more richer conversation. Again, going back to what really matters to that patient and the clinician being a facilitator to use all that information and design the most quality care to that patient. And yes, it's hard, but at the same time, the potential for it is so much. Yeah, that'll be my response.
What do you think the next big thing is going to be?
What is the next big thing? I think, okay, building on the digital digital healthcare, with all this data in our systems, and now with the rise of AI, what I'm excited about and I'm hoping to see in the future, we spoke about clinical decision support systems. Definitely, yeah. Can we use AI to make sense of all this data that we're collecting about the patients, to use that to predict where's this patient going to go? And with that kind of predictive information, can we design better decision making for the patient from an improvement point of view? All that data can also be used to identify gaps in our systems. We now have a much richer base of data to see, hey, we are not performing as well as we should be in this area. We are outperforming other locations or other benchmarks in these areas. Yes, let's use that information to understand our gaps. At the same time, understand what is it we are doing really well. So yeah, how we are going to use data, right? All this big amount of data, I think it's very exciting.
Excellent. So learning not only from our mistakes, but from what we do well, and hopefully helping others learn from it also. So this will move me to a more general question for the group, and I know many of you have academic backgrounds also. So what do you think the importance of locally conducted research is to our understanding of patient safety, particularly in diverse healthcare systems like in LMICs? And how can these insights inform global efforts to improve patient safety standards practices? Because I think, as Jinnah mentioned earlier, everybody wants to do exactly what Hopkins or MIT or Harvard is doing, but they're unable to do so or translate those things exactly. So maybe the local research or local data is needed. More of an open question. Maybe Jinnah can start.
Definitely local data would be needed. And then it can always be compared or benchmarked to other data, right? And also when you need to be careful what you benchmark to. So there's also needs to be local, regional, and then international, sort of three tiers of benchmarks to be able to do safe something safely and to be able to do justice to the data you collect. At the local level, though, the data has to be collected and has to be validated. We all have challenges with data collection and having clean data. So I think the first thing we need to decide on is what data are we looking for? Like what is important? What is the data that we need to look for and how do we do it? And we may do it as a pilot first and get, if it's disease burden, if it's something that we need to understand, how is our patient safety, what are our patient safety outcome in first tier cities and second tier cities? How do you do that? You get that data and then you start comparing it to other like regional areas, other hospitals in the region, and then internationally, and see where the gaps are and prioritize those gaps. It is important. It's a challenge that we all face to find good data everywhere in the world. It's not just particular to Pakistan. You have to find, and it's because we need to set up the objective first. Know where you want to be and find the data to help you get there, I think.
And building on that, can you hear me? Yes. And building on that, I think we all have the benefit of a phenomenal resource with the WHO Global Patient Safety Action Plan that takes out a vision toward patient safety and outcomes that need to be achieved out to 2030. And even in Canada and all the countries that I work with and that I'm involved with through ISQA, having people come together and focus on the research agenda or the improvement agenda around how to influence some of those broader safety indicators is a great contribution, because you know that the research behind the fundamental indicators of global patient safety, they're all there. They've been well researched, well endorsed by every country. And then if you look at your unique context and the research strength that you have to think about how you're contributing, I think is terrific. I have to say, I was so impressed yesterday to hear about the launch of the British Medical Journal, the Open BMJ, with highlighting the research and experience in Pakistan. That's going to be helpful for us in our countries and our global efforts, as well as in your own. But I would encourage you to think about that broader piece around how do you contribute to the global patient safety agenda to sharpen the acceleration of change when we're all working towards some common goals.
Shahid?
Okay. Yes. Yeah. At the beginning of my talk, also mentioned that measurement is very important and data is very important. And I agree with my colleagues that data quality is also very important. So we should be careful while benchmarking. I mean, first of all, yes, we need to use the standardized definition. As an epidemiologist, I think that's also one of the problems. When we are comparing all the indicators, we need to, first of all, select the most appropriate indicators, which measures really the patient safety environment, patient safety culture. Use the standardized approach or standardized indicators or standardized tools, which are, the reliability and validity already ensure, and then collect data and then benchmark and then accordingly take action. For instance, let me give again a real example from my country. First of all, at institutional level, of course, many years ago, I selected some indicators, use WHO definitions or the American Agency for healthcare quality and research agency. They have also very good indicators and everything is defined very well. We did one workshop on KPI yesterday, and I'm very impressed that everybody actually who attended to that workshop aware of all those issues, all those definitions and all those resources. Anyway, so we selected around at the country level 250 indicators, and with the standardized definition, some of them clinical, some of them managerial, So every 3 months, we are entering all data. Those data goes to the pool, but they are not even, as my colleague already mentioned, they don't, trust our even calculation, and mention you that we have good health information system and all linked to the Social Security and Institute and MOH. They are getting all data, raw data from individual level. They are calculating, for instance, they are calculating VTE rates, or they are calculating readmission after cataract surgery. And they first of all selected 10 for planning to pass value-based healthcare. That's the reason for that one. Anyway, so they are every 3 months, all the healthcare facilities enter all the data. They are calculating. They are benchmarking at the regional level, using dashboard, kind of, at the country level. And they are coming back. For instance, I'm the coordinator, so asking me that, Dr. Seval, your readmission rate from cataract surgery higher than your regional level and institutional level and country level. What are the reasons? And accordingly, it also directly again goes to the reimbursement system and not reimbursing 100%. So these are some methods that to improve your patient safety area. Thank you very much.
Fantastic. So, I think I agree with all of you that research locally, it sounds like everybody thinks is important. We look at our data, but I almost wonder if in LMIC's implementation research in how to implement these standards is more important. And I know this is an emerging topic. In the interest of time, I'm going to now start moving towards the end. I'm going to ask Dr. Zaki to maybe summarize our discussion so far.
Thank you, Dr. Asad. Very interesting discussion. So I've picked up a few points which I just want to summarize. So the first question which you asked, I think that's a very critical question. And that question actually links us to the why we are here. And I would think that as healthcare professionals, why do we exist? We exist to serve the patients. And this whole story started with do no harm. So even before we want to help our patients, we have to be that we are not harming them. So I think quality allows us to make healthcare safe. So our ultimate why is to make the healthcare ecosystem or system safe for our patients, and quality helps us. So improving every day allows us to achieve our ultimate raison d'etre, as we call it. So I think do no harm should always be in front of us, and that's our why, not just having better quality. That's the second is workforce well-being, and and WHO has included healthcare professional safety into patient safety. So I think that if hospitals want to take care of their patients, they should take care of their healthcare professionals. When you take care of your doctors, when you take care of your nurses and every member of the team, they will be able to take care of the patients in a better way. So I think that's an approach which hospital leaders should take. Take care of your healthcare professionals. The third, which one of my colleagues mentioned, and this is very close to my heart, is culture. So we talk about culture, and culture of what? A just culture. And we were discussing that justice in the society is different than just culture in a healthcare organization. There are different, mindsets, teamwork, respect, balance of courage and compassion. You have to, follow both. And who does that? Who establishes a culture or creates a culture? So that's where leadership comes in. And we have just published on the role of leadership and compassion in improving quality and safety. Technology, obviously, that's my bias. So I work in digital health. We have enough evidence that technology reduces preventable medical errors. Technology improves diagnosis. This, which is a problem, 20 to 40%. We can reduce the incorrect diagnosis through technology. So why not? Why would healthcare professionals or hospitals not use technology? So I think I would start with that. And last, research, as you mentioned. So I'll just say two things. Research has to be relevant. Research in Pakistan has to be different from research in maybe, Norway, because our context is different. So research has to be relevant and contextual. So that's my summary of the discussion, building upon what all of you said. So I think these are the points which I would take back. Thank you very much.
Thank you very much. Moving on to our chairman to give some closing remarks, given your tremendous insight, having been our special advisor for health. Thank you very much, sir.
Bismillah ar-Rahman ar-Rahim. First of all, thank you very much for having me, and I have learned a lot from the comments that very accomplished panelists have made. Let me first of all begin by saying that Riphah University has been championing patient safety for last couple of years. We have now 7th international conference, which is very heartening. And especially, I have attended few of the international conferences before by Riphah on patient safety. And I have noticed that a heavy participation by the students especially, which is great. Which is great because what we are not teaching formally to our students in their undergraduate education and training, is being served by these kind of conferences. And I think this gap filling by Riphah on patient safety and quality issues in healthcare is very, very appreciable. Let me make few comments, but to begin with, I want to deconstruct, first of all, few words and concepts that we use in this discussion about patient safety and quality. The title of this session is Global Perspectives. And somehow the word global has been, we equate it with international and high income countries. Whereas, and that's the connotation which comes, local and global. And with global, MITs and Harvards and Stanfords come to mind. Whereas the global really is low and middle income countries if we go by the population. So 75 to 80% of the population of the world in this globe lives in low and middle income countries. So the definition of global has to be rethought, and hence our discussions should take place in that context. So that's my first deconstruction. The second deconstruction that I want to make is that quality cannot be discussed in isolation. Quality has to be inbuilt into the system. Isolated attempt to improve quality in any aspect of healthcare will not be sustainable, even if it improves. If we think about, and as a student of health system myself, if I think about health systems, and if I think about health systems made up of, in terms of delivery, products and services, what products we deliver in healthcare has a very unique sense of quality. For example, the pharmaceuticals, medical devices, vaccines, there is no concept of these products without quality. And they are inbuilt from the point of conception in terms of research and development to the delivery of the product to the bedside of the patient. And heavy investments are made in these products. But when we think about services, the services are on their own in health system, and especially in the majority part of the word global, that is low and middle income countries. We have no sense of quality in health services. And it is slightly understandable, and as I will explain in a minute, but the point I'm making here is that the discussion of quality has to be taken up at a system level, not at a facility level. Even a good leader, a good manager, good administrator of a health facility may be able to sustain the quality standards and their implementation for his or her lifespan in that institution. But if system does not drive policy, it will not be sustainable. The third point that I want to make is also very interesting, especially from low and middle income countries context. And that is that I often hear, and pardon me if I sound a little bit critical here, the quality of care, the connotation of it is hospital-based and clinicians. Whereas when we talk about healthcare, healthcare is a much broader concept than clinicians and curative healthcare. In countries like us, going by what WHO is now saying, that up to 90% of the healthcare can be delivered and should be delivered throughout the life course of an individual at the primary healthcare level. But when I hear the discussions about quality of healthcare, I do not hear as much about quality standards and their implementation at the primary healthcare level, in the preventive healthcare, in the rehabilitative healthcare, in the promotive healthcare, and even palliative healthcare. it has somehow skewed to the clinicians and to the hospitals and to the it must be there. I'm not doubting that. I'm not questioning that. It's absolutely very important. But we need to expand our imaginations as health professionals, going beyond hospitals, clinicians, and curative care, and taking it to the realms where it has not been introduced as yet. Fourth deconstruction that I want to also share with you is that, and especially for students who have gone for lunch now, is that we need to understand the context. In our context, which is, we were talking about culture, but mainly we were still talking about culture within the facilities and within the healthcare system, within the hospital sector. Actually, if you think about it, in a culture of poverty, quality is not the main consideration. Access is the main consideration. When people are dying for lack of essential healthcare and essential medicines and essential vaccines and nutrition, the word quality comes as a second thought, as an afterthought. And this is very understandable. In a typical policymaker's mind, in a low and middle income country, he or she is obsessed with excess, not with quality. But what has fundamentally changed, in my view, in 2018 was when Lancet Commission on high quality health systems in the era of sustainable development goals, the time of revolution, that is the full title of that Lancet Commission, actually without mincing words said something profoundly very important. And that is that in low and middle income countries, less people are dying. Please, I need your attention to this. Less people are dying because of access to healthcare. More people are dying because of the quality of the healthcare. That fundamentally changed our thinking and our conceptualization about quality. And I think since then, and also, of course, the movement for quality and improvement in quality in healthcare is it has its history. I'm familiar with that. But I think that was a very turning point when people started thinking that it's not just excess. Excess may be even harmful. Excess may be even harmful. You may be taking horse to the water, and if that horse takes that water, it may die, actually. However thirsty that dog is, or horse is. So it is very critical that we now start thinking in discussions about improving and increasing access of the people to essential health care. And alongside that, in the same breath, we also talk about the quality of health services. And that's why I have stopped talking about, because I consider myself as an advocate for quality primary healthcare and not primary healthcare. Because in Pakistan, we have equated primary healthcare as a poor healthcare for poor people of Pakistan. And poor healthcare means lack of quality. Lastly, I'm sorry I'm taking a bit more time. Lastly, there are a number of frameworks. I have worked for 16 years in World Health Organization. I was part of when WHO was working on national quality policies for the countries. And yet, when these policies arrive at the desks of the policymakers in low and middle income countries, those are just words. They don't believe in them because they're obsessed. Their considerations are different. So what is needed now is, in my view, first of all, to take a more holistic approach to the discussions about quality in healthcare, taking it out of hospitals. When I say taking it out of hospitals, I don't mean devoid hospitals of this, but also take it to the rest of the healthcare system. And when I say that it has to be made part of the system, that will start with our education and training of health professionals. It will not change through a conference. It will change by changing or introducing the curriculums in the undergraduate trainings of health professionals, and I'm very deliberately using the word health professionals, not just doctors. Doctors chaudhary nahi hai quality of healthcare ke. It is the whole team. It is nurses, it is paramedics, it is dispensers, it is vaccinators, it is community health workers, and so on and so forth. We think that we are the custodians of quality. Even if we are in a team setting, we cannot deliver that. So, lastly, and very importantly, I think that what is needed is, and that would be my one, or let's say two recommendations for your considerations for this conference and maybe for the future. First is that little by little in low and middle income countries, regulatory authorities for health services are emerging. I think that we also need to have third-party accreditation organizations whose genesis should be taking place from within the system. They should not be imported. They will not be relevant to our conditions. Can you believe that next door, Khyber Pakhtunkhwa province has 85% of population living in rural areas, being served only by public sector primary healthcare facilities which are not working. So what are we talking about? Where are our priorities? How we will fix that? So that's the point. I think that we need to, along with our regulatory authorities, with their indicators for improving quality of healthcare, we also need independent third-party accreditation organizations emerging from within the system in low and middle income countries, who should learn from experiences from high income countries, but their genesis must be local context. And lastly, if we can come up with a model curriculum on quality of healthcare, which can be introduced at undergraduate level in different cadres of the health professionals in Pakistan, that will be a great service and that will be the game changer. I thank you very much for your attention.
Thank you very much. Okay. Well, I know I'm not going to talk Dr. Miracha, but what I will end up with is I think we have lunch being served.
Just for a brief resolution, I now call Dr. Aisha Abdullah from Peshawar Medical College to present a resolution on the safety of healthcare professionals in Gaza, Palestine. A very humane gesture. Ladies and gentlemen, please encourage Dr. Aisha Abdullah.
Bismillahirrahmanirrahim. Assalamu alaikum and good evening. I'm going to take a few minutes to catch my breath. I've got a breathing problem. From this forum that has committed itself to patient safety and quality improvement in healthcare, I would like to propose a resolution. It is about condemnation of attacks on healthcare professionals, patients, humanitarian relief workers, and destruction of healthcare infrastructure in Gaza by Israel. I'm going to now read out the details of the resolution to you, and at the end, I would request for your vote. We, the healthcare professionals and participants of 7th International Conference on Patient Safety, in view of the escalating armed conflict and humanitarian crises in Middle East, Gaza, and the surrounding areas, do hereby reiterate and emphasize the following. We recognize the importance of upholding human rights, including the right to life, dignity, and access to healthcare. We are deeply concerned by the escalating violence in Gaza, which has resulted in the loss of life, destruction of hospitals, and endangerment of healthcare professionals. We are alarmed by the reports of mass executions, hand-bound bodies in mass graves, and the targeting of medical facilities, with total destruction of hospitals in Gaza. We insist on emphasizing the critical role of healthcare workers, and we insist in this role to be allowed to be played effectively in providing essential services during armed conflicts and in peace. We strongly condemn the killing of over 500 doctors, nurses, and healthcare professionals in Gaza. Express outrage at the destruction of hospitals and universities, which undermines access to medical care and education and leads to a perpetual cycle of humanitarian crisis. We denounce the killing of patients and the inhumane mass executions witnessed in hospital ruins. We urge all parties involved in the conflict to respect international and humanitarian law and protect healthcare workers, patients, and civilians. Reaffirm the right of civilians, including women and children, to live free from violence and fear. Demand unrestricted access for humanitarian aid and medical supplies to reach the affected people. Commit to continue raising awareness about the plight of civilians, patients, and healthcare workers in conflict zones and advocate for their safety. If you agree with this resolution, please raise your hand and say yes. We want to see and hear. Yes. Thank you very much. And may Allah bless you.
Thank you, Dr. Aisha. Lunch? Okay. We will now pause proceedings for formal lunch and prayer break.